I'm one of the new endocrinologists at Stanford. This is our nurse practitioner, Olivia Chu. This is our other endocrinologist, Dr. Hoffman. And then you heard from Leslie earlier this morning with the Cushing's Society. So this afternoon is more very fluid Q&A. We don't have PowerPoints. We're not going to be lecturing at you. I think 4 hours of lecture is a good exposure to what we did in med school all day, every day. So if there are any questions, we can start with that and prioritize, any questions from the live audience? If not, I'll go to questions from the Zoom audience. I can actually, Olivia, I'll repeat the question because the Zoom people need to hear it anyway. Yeah. Oh, that's a great question. Yeah. So the question is, for patients, besides clinicaltrials.gov, are there any other places for them to see if they can be a research participant for new drugs or therapies for whatever condition they have? No.
I'm pretty sure that they should all be listed on clinicaltrials.gov just because they get a code number and there's a format that they have to fill out. But I do know that Europe has their own separate one. And oftentimes there are benefits for participants to travel to a site. So I'm not sure if that works both ways about going to Europe or coming over here from there. CSRF recently partnered with, I forget what they're called, but it's like the European clinicaltrials.gov. And so we have a link on our site and they've kind of linked to us. So there's at least two, depending on where you are.
Yeah.
Yes.
Yeah. So the question is, just general advice on the topic of, brain fog after acromegaly or Cushing disease treatment. Is that correct? Yeah.
There's really well documented brain fog, concentration, memory, focus, ability to sit still, stuff like that. I think a number of people afterwards, if they pursue something, if it bothers them enough or it affects the things that are important in their life, like their work, I'm talking about myself right now, I ended up going to, I did some neuropsychological testing because it was offered at my hospital. I didn't have to seek it out. It was just there. And that now once I did it, and then I hear other people talking about it, it can be helpful to help map things that they can pick up on. But if you're already a high functioning person, then your results on that might be, you look normal. Everything's great, go away. It's like, I feel like it'd be really helpful for someone where they got severe impairment where it can be picked up on the testing and then they can get a report that says this person has impairment in this department or whatever. What I ultimately ended up doing was I went to a psychiatrist and I was tested for ADHD, which, I mean, my ultimate goal was to try Adderall because I've heard people talk about getting it, and I'm not suggesting that anybody take Adderall unless it's the right thing for them. But I recognized from having a child who went through that testing back decades ago that they kind of test all these different areas. And my answer was like, no, to like, is it hard for me to sit still? Do I have problems with A, B, C, or D? And the answer is just no. But then when it came to like the brain fog, do I have trouble concentrating? Do I have trouble like recalling, and like this? Yes, everything was yes in that one section. And so I don't know if it's specifically ADHD, but it's like it, and it's treated. I mean, I'm treating it like ADD, and I'm having the results I want to get my work done, to have that type of focus and concentration in the moment that I need it. I don't take it when I'm not working or whatever. There's other things that people can do, but there's also research showing that like the areas of damage from long-term cortisol, high cortisol, but there's also damage in your gray and white matter. Dr. Susan Webb did a lot of work on that. I know I've read a couple of her papers, and if you kind of understand the areas of the brain that have shown some of that degradation and then know what that section of the brain does, I think that's further support for it. But then what your local doctor does with that information, who only knows, there's like a lot of self-advocacy can possibly get you at least something to try, something different, recognition, something like that. It's real, so real. It's the worst. It sucks so bad. It's awful. Yeah, it's hard. Yeah, it's hard. Validation.
No, I agree. Earlier in the session, we had another participant ask a very similar question. And so to Leslie's point, it is very real. So we see these patients. And so even though you're, surgical cure, you're in remission, you never get it. Your IGF-1 levels are normal, your cortisol levels are normal, but you still don't feel like before you were diagnosed or before the surgery. And as endocrinologists, I don't know, you can chime in afterwards. It's very, our job is to make sure that after the surgery, you don't have a hormone deficiency contributing to these cognitive disorders. So after surgery, if you become growth hormone deficient because, they took out a little bit of normal pituitary in the attempt to take out the tumor, replacing people with growth hormone if they are deficient can sometimes help with cognitive and mood disorders. But if it's not, if all of your hormones are sort of normal, where as an endocrinologist, it's hard for us. And so I often will refer patients to psychiatry. And at Stanford, we have a neurology cognitive center, which is nice because they do a whole neurocognitive exam and they give you medications that are not in our, like Adderall. Like I don't prescribe Adderall regularly, but if that is something they feel would be helpful to you, I think that would be an excellent resource. Or other psychiatric meds that are just something an endocrinologist does not normally prescribe. Yeah. And then one of the attendees, to answer the questions about clinical trials, said you can try clinicaltrialsregister.eu. Okay, I'm not. Okay, I'm like, I don't. Okay. Any other questions? Yeah.
Well, I think one of the issues is that it is a
Sorry,
rare.
Dr. Let me repeat the question.
Oh,
so that
the question
view,
is that general practitioners and general internists rarely see patients with Cushing's, and it's very difficult for them to even think of Cushing's as part of the diagnosis when people come in with high blood pressure or diabetes or depression, which are very common early on. So the problem is, of course, it's rare. The symptoms are non-specific. They're not, most patients with high blood pressure don't have Cushing's, obviously. And in the past, doctors were looking for the obesity. But in the last 30 years, with the obesity epidemic in this country, so many people are obese, that doesn't help anymore either. So it can take quite a while until some of the sort of the later manifestations, like the abdominal stria, the purple marks on the abdomen, which usually take much longer to appear before people begin thinking of the diagnosis. But for all rare, this is a problem of all rare diseases, that physicians are told to, when they hear hoofbeats, to think of horses and not zebras, to think of the common things, and most of the time they'll be right, and that's what they should do. But they have to be cognizant that occasionally a zebra will call through, and you have to be able to do that. And it's a matter of educating people to think of these things.
I think a new thing that we're focused on now after seeing, so let me back up. Earlier this year, we went to a conference for nurse practitioners. And so any type of nurse practitioner, not just endo. This is the second year that we've attended professional conferences that were non-endo. So last year we went to gynecology and obstetrics one, which was amazing because we talked to all these doctors who just see PCOS all the time and treat their PCOS patients all the time. There's all these sessions about PCOS, all these great like supportive things in the expo. And every single time we talk to a gynecologist and we're like, if you have a patient with PCOS and they're telling you they're doing everything you told them to, but they're getting worse, like, do you ever test their cortisol? They're like, what? We're like, what? What? And then, so then this year we went to the nurse practitioners and we have our nice banners that say Cushings and, people come over, yeah, Cushings, whatever, like looking at the stuff on our table, maybe like, do you test your patients for hypercortisolism? And they're like, oh yeah, I've got, like this. And they just knew that word so much better. And we were just like mind blown because we've been Cushing, Cushing, Cushing. So maybe it's taking a different angle. Not everybody loves that word. Some people are very like protective of Cushings and the sanctity of Cushings or whatever, and they're hesitant to use that word, or they think it's because a pharma company somewhere did a thing about hypercortisolism or whatever. But the fact of the matter is, if all these non-endos understand hypercortisolism, who cares if they're going to screen faster? Even if I think giving them the understanding and support that they are qualified to screen. Now, if they find someone that they probably has endogenous, Cushing's disease or whatever, nobody expects you as, a nurse practitioner or primary care to get them through to surgery and cover all that, but you can screen everybody. If they have certain things, you could screen them. It could be part of screen them. I mean, that's really, I feel like our strong message now is screen them. Like, you have the ability, here's how, like share with them like kind of tips or like an order of the testing and why it's done that way so that they feel empowered to do that. And so we've increased the number of conferences we're going to that are non-endo. That's one angle of it. It's still going to be a challenge though, because there's always going to be those doctors that are like, it can't be that, or it's too rare, or I don't know, like you said, the obesity issue with that used to be one of the things that like made it easier to find, and that's such a problem here anyway. Same with high blood pressure and diabetes, problems with periods, depression, especially because this tends to happen to women of a certain age, and that stuff's even more relevant in that age. So it's just so easy to dismiss it or call it something else. But I feel like if we can normalize the screening and normalize non-endos having, yes, you can do it. You don't have to just like, oh, I don't even know what that is. You need to go straight to a specialist. So that means they get an appointment in 8 months. They go on Facebook and then they get filled with that poison, and they spend all this time just waiting. And if it's not endogenous, tumor cause, then an expert specialist might not actually be the one who needs to do that full diagnosis and work them up and stuff, So we're trying to go that angle, see what happens.
So we have a few questions from the Zoom audience. The first is, what if a Cushing's is left untreated with no surgery or medications? What is the risk? Can a person live with Cushing's long term? I can take that. Okay. So it's not binary. It's not yes or no. So can a person live with a little bit too much cortisol? Yes. So in those patients, there is a condition called what we call subclinical Cushing's, where your cortisol is a little bit high, but you don't have significant comorbidities at that time. Do we recommend that you have like a pituitary Cushing and not get treated? Most likely not, because over time that can lead to health risks, specifically metabolic. So you will at some point develop diabetes, high blood pressure, risk to bone health, osteoporosis, risk to your mental health, psychoses, depression. So in general, if you have a known Cushing disease, either in your pituitary gland or your adrenal gland, and you have symptoms specifically, then we highly recommend you aim for curative treatment, either with surgery, and if that doesn't work, medical therapy, to keep your cortisol level at a normal range.
The other thing is that patients with Cushing's are at very high risk of developing what we call opportunistic infections. Those are infections that normally your immune system would be able to fight off, various fungal diseases, for example. But when you have high levels of cortisol, your immune function is compromised quite a bit. And we frequently, in the past, before we had good treatments for Cushing's, would see patients dying of infections that normally would be easily cured.
Yeah. I mean, yeah, the list of complications can, there's electrolyte abnormalities, blood clots, ulcers in your stomach, there's more. So I think that answers that question. The next one is regarding Cushing's. What is a healthy cortisol level? So the reason why we sort of chuckle is because cortisol, as with many of the pituitary hormones that we make, really varies depending on the time of day, and it's normal. It's normal physiology to have a higher cortisol level in the morning than it is to have it at night. And so I'm trying my best to answer this person's question. So, to make sure that you don't, so Cushing disease is having too much cortisol levels. And so we do not diagnose Cushing disease just by checking your cortisol level at one point. We do dynamic tests. What happens to your cortisol if we give you this medication or this steroid, or what is your cortisol level in a 24-hour period? And so we do a 24-hour urine collection. Doing a one blood test of cortisol does not help us really diagnose Cushing disease because, like I said, the hormone levels can fluctuate in a normal, healthy person quite variably in a single day, minute to minute, hour to hour. In terms of low cortisol levels, that one is more easy for us to test. And so if you just had surgery, for example, and you're worried that you might become panhypopit, like Dr. Hoffman talked about, or have low cortisol, then a morning cortisol is the best indicator. So between 6 to 9 a.m., that is when a normal person cortisol should be the highest. So we ask the patient to get the blood draw in the morning. That's very important. And different lab assays, different, practices, but I think in general, a morning cortisol above 10 is very reassuring that you do not have adrenal insufficiency. A cortisol level less than, again, this fudge it a little bit, plus or minus 3 plus or minus a few, less than 3, then we'd be really concerned that you have adrenal insufficiency, not enough cortisol hormone. And if you're in the middle, that's when we might consider something like a costantropin stim test to further diagnose. Because, at 6 a.m. cortisol of between 3 and 10 could be normal. It's just hard for us to say. Okay. I think that answers that. And another question regarding Cushing's testing, thoughts on cyclical Cushing's? I'll leave this one to Dr. Hoffman.
I've seen a couple of cases of cyclical Cushing's. This is a very rare part of a rare disease. And when people have Cushing's syndrome, usually it's Cushing's disease with pituitary tumor. That's quite clear. You can make the diagnosis. The cortisol levels are very high in the urine and in the blood. And they have all of the signs and symptoms of Cushing's, and it spontaneously goes away and then reappears usually a month or two later. And this can go on back and forth, back and forth. And because it goes away sort of by the time the patient, often the patient will not get to the doctor until it's gone away again. It can be very, very difficult to make the diagnosis and to treat, because there's nothing harder in all of endocrinology than to make the diagnosis of Cushing's. Even if a patient comes to me with the supposition that she has Cushing's, to make the diagnosis can often be extremely hard, because all the tests that we have can be somewhat equivocal. So as an endocrinologist, this is always the hardest challenge for me. And I think all endocrinologists would probably agree, not just me. Cyclic Cushing's makes it much harder because it comes and goes, and you really can only treat it when it's there. And you're trying to figure out where the pathology is. Is it a pituitary tumor? Is it an adrenal tumor? Both pituitaries and adrenals tend to make little tumors all the time. And about 10% of people at any given time will have a very small pituitary adenoma, 2 to 3 millimeters, not making anything, not causing any problems. And we only find it if we did an MRI scan for another reason. So it can be very difficult to chase down cyclic Cushing's. But again, it's exceptionally rare. I've seen 2 cases in my 40-some-year career, and it's a challenge. That's all I can tell you.
I have a couple of things to add. So, from the patient point of view, things I've heard online or in other patient meetings, so I have 2 things to say. One is that I don't believe, I could be wrong here, but cyclical does not mean I wake up feeling okay, feel bad all day, and I feel better at night every single day. It's not like a daily thing, like bad then, good, bad, in the course of a 24-hour. And a lot of people, I've seen them on social media describing their cyclical Cushing's in that manner, even when they haven't ever been to an endocrinologist yet, to actually have a cortisol test. So I'm not going to sit up here and guess out loud my thoughts on that or how that happens. But would say another thing that you see people doing is getting very frustrated when, especially if a doctor says, well, I think you might have cyclical, and then it seems like they don't do anything. But it's they're usually given more saliva kits. So when they feel that cycle coming back on, they can immediately take a test that's a validated, correct test, and then hopefully get in with their doctor. And it can be really frustrating to just be told, well, just go home and wait for the next time you feel bad. And they might feel like they need to switch doctors, and they might feel like they're getting dismissed, and that's not what's happening. Like cyclical, you have to map those out. Like you got to kind of catch. I think the diagnosis is like 2 highs and 3 troughs, or like once it's you've mapped it or caught the pattern.
Most of the patients, most of the patients with cyclical Cushing's have it for a couple months at a time, then it goes away for a couple months at a time. So it's certainly not a daily fluctuation, and it's not even usually a few days. It's a prolonged period, and we don't understand why it happens. But one of the other frustrations for patients with Cushing's, I think, is that it's difficult to make the diagnosis. And not uncommonly, we'll have a patient come in who may have Cushing's, and we do the tests, and they're all very equivocal. None of them are really certain that the patient has Cushing's. And the question comes up as to what should you do? Pituitary surgery is very invasive and has potential side effects. You don't want to do surgery unnecessarily there or on the adrenal glands. And sometimes we simply have to wait and retest over a fairly long period of time to make sure that we really have the right diagnosis. Or if something else might appear that could be mimicking it. But we commonly will get at the urinary free cortisol, for example, which is a commonly used screen test. The normal value is up to about 50. We see patients with levels around 60, 65, just slightly elevated. And they may have some or maybe none of the clinical signs and symptoms of Cushing's. And it becomes difficult to know. We don't want to do harm, first of all, but we don't want to do harm by waiting too long either. And it is frustrating for both the patient and for the physician when we can't come up with a clear-cut diagnosis right away.
Yeah.
I've been recently getting tested and taking and I was diagnosed with ADHD as an adult, so I take vitamins. And unlike the first time, I went through the whole sort of series of progressive different tests to establish that I had Cushing's. When I did the dexamethasone suppression test, the endocrinologist consulted with me, and she pointed out that vitamins could interfere with the and interpreting the results. And so she suggested doing midnight salivary cortisol. And I read some about that mechanism of action with professionals. I don't recall what it was. But it did make me wonder, especially since we've been talking about treating cognitive symptoms, if that is true of that class of medication. That we maybe also need to spread the word to providers who treat people with disease to consider the test that they're using depending on.
Yeah. So I have to summarize your question. So there's a patient who is on Vyvanse, which is medication used to treat ADHD, and whether or not that could affect the result of a 1 milligram dex suppression test. Sort of summarize. Yeah. So medications for sure can interfere with our lab testing. The biggest thing is dexamethasone is a steroid pill that we give you, and we tell you to take it at midnight. And the goal is, in a normal person, it should lower your body's ability to make cortisol. So the next morning we tell you get blood draw, your cortisol should be low. That is assuming that your body absorbed and metabolized that dexamethasone level appropriately to the point where it is high enough to get this appropriate response. So if you're taking medications or doing things where the dexamethasone gets metabolized sooner, then your cortisol of the morning can look high. And we might think, oh my God, this is an abnormal test result. But it really could be because the dexamethasone, you did not respond to it like a normal person would have. And so medication interference is definitely something that we have to look into. And there's just a list of, and so, but to answer your question, not all psychiatric meds or, have this effect. We just have to know. So great. They're not the same. So it's really just very medication specific. So that's why, yeah, I don't want to tell you, you should never take any psychiatric meds ever again. Like that's, yeah. Mhm. Yeah. Great. Did I answer your question? Okay, great. We do have a few more from the Zoom. Does an irregulated sleep cycle impact the validity of that window you use for an AM cortisol draw? Which is a great question. I give the hard ones to Dr. Hoffman.
Well, if you're working the night shift and you're usually working the night shift, then your circadian rhythms are altered and you'd have to change when you took the dexamethasone. You'd want to take it before you went to bed and measure it when you got up. That can be kind of difficult sometimes. So that may not be the best test to do. And even the midnight cortisol test, you'd have to take that just before you went to bed. And I think it makes it very complicated. And then somebody who works the night shift, I would have a 24-hour urine cortisol is the best test probably.
Yeah.
But what do you do in patients? How do you instruct patients on the DST?
We just usually have patients take the medication at 11 p.m. and then the lab draw at 8 a.m. Does that sound right?
Yeah.
Yeah.
So the dexamethasone suppression test, that one, it's really the steroid that's doing it. The steroid, that pill should lower your cortisol level if you did not have Cushing disease. For this patient, they're just saying a baseline morning cortisol. This is the one to check, what is your normal healthy cortisol level in the morning. And so I agree with Dr. Hoffman, that really can depend on what your day is, because in most people who wake up in the morning and work during the day, your cortisol level is highest when you're upon awakening. So if you work the night shift and you're sleeping during the day and you're awake at 6 p.m. instead of 6 a.m., that baseline cortisol, should we do it at 6 p.m.? And that's where it gets very complicated. And so to Dr. Hoffman's point, I think in these scenarios, doing a 24-hour urine cortisol would be the best because then we know what it is in a full 24-hour day. Late night salivary cortisol has the same issue in patients who are night shift workers. And so sometimes, and it also depends, like for instance, if you're in the medical field and some days you're doing nights and some days you're doing days, then you can forget it. We don't know. But if you are consistently always working nights, then we do, for late night salivary cortisol, we do say, do it when you will be going to sleep. So instead of doing a late night salivary cortisol in a normal person, when you go to bed 10 p.m., 11 p.m., we say, if you're going to bed at 6 p.m. because you worked all night, then do the late night salivary cortisol at 6 p.m. if you consistently work, nights.
Am I allowed to ask questions?
Oh, yeah.
Related to that, patients often ask me, when should I take my hydrocortisone replacement? Is there a particular time of day? What if my schedule changes? Do you have any input into timing of hydrocortisone dosing? And, is it twice daily, 3 times daily?
Yeah. Sure. Yeah. So if your schedule is really complex, then something like a longer acting once a day dosing like prednisone or dexamethasone might be better, and to take it at the time when your day would start. Because even though these medications are longer acting and technically 24 hours or even more, there's always a peak. It's always highest when you first take it, and then it tapers off by the 24th hour. So if you are a consistently night shift worker, then taking it at 6 p.m. when you're waking up and going to work, and then you sleep during the day would be helpful. For hydrocortisone, yeah, so the key is to mimic what your body does normally. And in the normal person, we say take a higher dose in the morning because that's when your cortisol normally should be higher. But if your cortisol normally is not higher in the morning, it's higher at 6 p.m., then I do shift it, or even taking it 3 times a day to be safe, which other practitioners do. The half-life of hydrocortisone is less than 12 hours, really. But just prescribing someone to take a medication 3 times a day is just it's not practical, it's unrealistic, which is why the more common practice is 2 times a day. And we know that that's safe. You're not going to die if you take it twice a day instead of 3 times a day. So if you want to do, a very high dose, a medium dose, and then a lower dose 3 times a day, that is reasonable.
I think you don't want to take too much at night. It will keep you up and increases appetite. It's the worst thing. You stay up at night and then you eat. So you don't want to do that. To be perfectly honest, when I prescribe hydrocortisone, I usually tell people to take it 2/3 in the morning and then about 1/3 between noon and 3 o'clock. I know most people can't do that every day. Most people, it's very hard to take a pill twice a day, especially if you're asking someone to take it in the middle of the day. And I always ask patients how often they miss their afternoon dose. And if they're missing it more than half the time, then I suggest they switch to prednisone, which gives them a longer lifespan. There is a drug available in Europe that gives you, it's sort of a delayed release. It's a pill that of hydrocortisone where the sort of the outer core is immediately released, and that gives you 2/3 of your dose. And the inner core is delayed release, and you get that release later on. And I know some people, I know the people who started the company, and they're very hot on it. But some people actually prefer that. I'm not sure it gives you that much more benefit over prednisone, but that's one of the newer things that are coming along. It has not gotten FDA approval yet, as far as I know.
All right, we're getting a lot of great questions from the chat, so I'm going to move a little faster. So the next one is, for a cosentropin stim test, do you recommend using an IV or unique sites for each draw? So to summarize, in case you forgot, so a cosentropin stim test, cosentropin is just synthetic ACTH. That is the hormone made by your pituitary gland to tell your adrenal glands to make cortisol. So when we give you cosentropin, we're just giving you man-made ACTH, and that should tell your adrenal glands to wake up and make cortisol. And so if you have adrenal insufficiency because your adrenal glands don't work, we give patients this cosentropin and their cortisol does not rise because their adrenal glands can't respond to it because it's, you know, dead for whatever reason. And so for IV or unique sites for blood draw, we just do a routine blood draw. So if a phlebotomist wants to draw the cortisol from, you know, an antecubital vein, we don't have a preference, not that I know of. It shouldn't affect your cortisol draw no matter where they do the draw. And the cosentropin, yeah, it's given IM. So to answer your question, no, it should not affect it. The next question is, does your baseline cortisol from a peripheral blood draw have to be elevated the day you do your bilateral inferior petrosal sinus sampling in order for the results to be accurate?
So the question has to do with, first of all, in order to do bilateral inferior petrosal sinus sampling, you absolutely have to have the diagnosis of Cushing's syndrome made. That is, you have to know that the patient actually has Cushing's syndrome, because otherwise you'll get false positive results.
Can you explain the IPSS?
Yeah.
I don't think
so. The IPSS is a test where a catheter is placed usually in the groin, and it's sent up into the head, and it draws the blood right out of the veins that drain the pituitary gland. And we then can stimulate the pituitary gland to secrete ACTH, by giving either a drug called CRH, which really isn't available anymore, or we give desmopressin. And that will cause ACTH to be released from the pituitary gland. We do this to try to make sure that the patient's high ACTH levels are coming from the pituitary and not from an ectopic source, that is a source of a lung cancer or a pancreatic tumor or some other tumor in the body. But we don't do this test until we know we actually have the diagnosis of Cushing made by other tests. But we don't make the diagnosis of Cushing's by getting a high cortisol that morning. So we don't depend on that day's cortisol level, but we do assume that they have Cushing's. Now, the only time this becomes a problem is in the cyclical Cushing's issue, where people have Cushing's for a couple months and they don't have it for a couple months. But you see them when they have it, you schedule the test. That test takes, isn't done for 2 months. But that's, again, extraordinarily rare. So we don't depend on that. But we do depend. You cannot make the diagnosis of Cushing's by doing this test. All you're doing is distinguishing between pituitary-based Cushing's and Cushing's elsewhere.
This is a great question. If a Cushing's patient is in remission, what maintenance do they have to keep up with and how often? I feel. Yeah. Okay. So the other question is, patient had Cushing in remission, what routine testing do you have to do and how often to make sure you stay in remission?
Well, there's several kinds of remission. If you can be in remission if you're still taking drugs to control the Cushing's, in which case you're probably getting lab tests every 4 to 6 months, probably. If you've had surgery and you're in remission and you feel like you've been cured, usually after about a year or two, you don't do any routine screening necessarily, and you're waiting for any symptoms. Now, if you've had a pituitary tumor, you'll have MRIs probably for the first couple of years, every year, and then maybe spaced out. But I don't think after about 2 years, there's really no good data as to how often you need to do screening. And you would screen the same way you'd screen to make the diagnosis. Many patients who've had Cushing's, who then have a recurrence, almost always know they have a recurrence. Even before any of the real signs of the stria coming back or diabetes or anything else, they sense that something is wrong, and they should come and have testing.
And to add to that, so interpreting the person's question, so if you had surgical remission, as in like they took it out, you're like cortisol levels, in some ways having adrenal insufficiency after the surgery is a good sign that you're in remission, you're come back. In that case, you're going to be in hydrocortisone. So if you're on hydrocortisone, then there is no monitoring of your cortisol levels afterwards. And then if you're on medications to keep your cortisol levels low, then you're not cured per se. The tumor is there. We're just giving you meds to keep your cortisol levels to stay low. And so in that case, we check cortisol levels to titrate the medication doses, really. Okay. And then, okay. Are there any other questions? There are some questions here, but they're very specific to the patient. So I want to prioritize any general questions that I think other audience members might be beneficial.
We didn't. And so it's sort of a way like kind of something similar to that where we can touch it like that. I feel like sometimes it's potentially
Well, at the moment, we don't have any testing like that. It's not that simple, actually. And I think that if you're in a situation where you feel like it's coming back and the test is normal, again, making the diagnosis of Cushing's and recurrent Cushing's is very difficult, and you have to often do multiple tests and wait over a period of time. And you often have to have patience and wait and see what develops, because sometimes in early stages, you can't really make the diagnosis.
And this isn't going to be helpful anytime soon, but there's a company called DermaSense, and they have applied for a grant to look in. They've got a device that's similar to a thing. It tests interstitial fluid. Just don't ask me what that means, but it's just another potential way. Like if they do a trial and it turns out it's successful, then that would be a new way to test for a patient to do at home. And it might be like a longer one. It might take more readings than just like one spot reading, or like a 24-hour jug of urine. Yeah, I would definitely agree that most patients I talk to about it, they know long before the test shows again that they're in a recurrence. It's kind of, I did. It's just it's back, it's just it seems like whatever was like the most bothersome, and it starts happening again, you're like, I'm sorry, what? Like, like for me, it was like not being able to sleep. It is a particular, like not being able to sleep and feeling crazy in the same time. And then like the sweat and certain characteristics for me, I knew it was back, and people, oh no, it wasn't. It's because we're traveling or something, like make excuses because you don't maybe necessarily look like it yet. But I just feel like the majority of people, if it comes back, it's just there were certain things that were very like that made the definition for you and your body. I feel like they just start creeping back in. That's what it sounds like most of us, and it's different for different people. But
one potential risk for you mentioned I'm a psychologist, people who are not very in touch with their what's going on for their body or who themselves explain away. Same thing when you're this idea of stopping lab screening after a certain point. For 2 years, it's very there might still be a place for something, or even saying, is my blood sugar increasing over time, my blood pressure changing over time, some of the other secondary conditions. And aren't as easy.
No, I think you're right. It is very, each patient has their own sense of what it is that's coming back. And I mean, if you come to see me, you're going to be coming to see me for the rest of your life. I don't let anybody go because I think pituitary patients need lifelong follow-up.
And part of your question was about people aren't as aware of themselves and so maybe stop testing. Like if they have successful surgery and once their cortisol kicks back in, a lot of times people just stop going to the doctor, even if they're still within a time period where the endo would still like to be following them up and testing them. But then, like you said, perhaps it would be nice if, once we've had these issues and we know the roles that cortisol plays in our life and we know what it feels like to have high cortisol and low cortisol, I'd like to keep having my cortisol tested for the rest of my life. I don't want to just drop off, So, I mean, I guess I don't really have an answer to that. It's just sort of like I agree. But a lot of times I hear people and they're like, oh, I know I should have been going, but as soon as I got better, I just wanted to stop. I just didn't want to go to that doctor anymore, or they had surgery or got seen in another state and now they can't. And so they just sort of, just stopped, or their local doctor doesn't understand it. So they just, whatever, they thought they were better. And so, yeah, agree.
Yeah.
You're talking about patients asymptomatically predicting the trigger. Is there any literature? I know there was like a constant. Is there any information about how to find that view? What it relates to what
I don't know if there's any scientific literature on this, but so many patients have told me this that I think all people who see patients with Cushing's know about it. I don't know if there's anything that's written.
I know what cat you're talking about, though.
Yeah.
It was a fun
Yeah.
story to read about. I mean, sad, but
I think it's helpful to see the same provider. I feel like patients who have seen me over the years, they may not remember how they felt a year ago, but I wrote it down. And so I can remind them, hey, remember you were going and you were playing tennis this frequently and you were crashing. You've come a long way from there, or, different symptoms that they had. And so I feel like that's helpful, some continuity there. And that's kind of why also helps us to kind of understand our lows too. So with adrenal insufficiency, how do you feel when you feel low? Some patients don't know, when do I stress dose? When do I double up when I go to the gym? These are questions that they're not sure about. And so sometimes over time, we can kind of figure that out together. We figure out, oh, when I have this particular kind of nausea or this particular lightheaded feeling or this muscle aches afterwards, those are my symptoms that I need to increase my dose. And that's usually helpful for patients to kind of get that feedback from their providers. And so, call us.
Yeah. If I had heard your comment about a cat, detecting when people are going to die 2 years ago, I would have thought I was like, what is he saying? But I totally believe you, because there are dogs who are trained to walk around with patients with type 1 diabetes or diabetes and detect when they will get low blood sugar, and they are accurate when they start barking at their caregiver, their owner, and then the owner checks the blood sugar and it's truly low before the person themselves realize they have a low blood sugar. So I totally believe these things now, and whether or not these animals or even patients themselves, they just, there's something wrong and they just know it. And, it's like, there's no, to our knowledge, scientific reason, but I'm sure it's real. Yeah. And then, this patient is asking, is there any data on Cushing's being familial? Does it have to be more than one person in a family having it? So these diseases are rare to begin with. And so, but to answer your question, yes, there are certain gene mutations that can make you have a predilection that you can pass to having a pituitary deficiency or a pituitary tumor, that if it is in your germ cells, that you can pass on to your child. I don't know if you want me to like list these genes in general, but to answer your question, yes, there are gene mutations that is, if it is in your germline, your eggs or your semen or your sperm, that can go to your child and make them predisposed to either having congenital diseases at birth. There's genes that can have you have adrenal insufficiency at birth. And there are genes that make you more predisposed to having Cushing disease, more aggressive versions, but also earlier in childhood.
You're talking about stuff like multiple endocrine neoplasia and Carney complex and things like that. Okay.
Yeah. So those are, so there are even syndromes. But Carney complex is a little bit different because Carney complex, you have Cushing disease from the adrenal glands. Correct me if I'm wrong, Dr. Hoffman, but it's micronodular adrenal hyperplasia. So the cortisol comes from your adrenal gland. It's not a pituitary issue. So you can have Cushing's. It's just the high cortisol is driven by a different reason.
I believe so. These are extreme. Carney is very rare. These are uncommon causes of an uncommon disease.
Yeah.
So most of them are not.
Yeah. And to help, we do not routinely, unless you tell me my sister also has a pituitary tumor, I have a pituitary tumor, my aunt, on my dad's side, then we would test you. But if you yourself singularly, which is 99% of the case, have a pituitary tumor, we do not, it's not standard of care to tell you to have you get genetically tested. Okay. And then, for Cushing's, what is a good approach for a patient to navigate and advocate informed consent to make the best decision? Sometimes patients don't know what to ask. Which I agree. So, I'm the only doctor in my family. And so when my brother asked for my advice, I'm like, well, like, did you say these things to the doctor? He's like, well, how am I supposed to know? I was supposed to ask these things to me. Like, I don't know. So I totally empathize. And so it's very hard when you, especially, we can't expect general practitioners, to your point, we can't, they can't know everything. It's just, and these are rare. Like we cannot expect them, despite all the years of medical school and residency, to really know all of these things. And it's hard. So, I mean, my, general opinion is, there's no harm in asking for a second opinion. Absolutely no harm. And so as a academic center, we get, the patient has an endocrinologist and just wants a second opinion. And oftentimes I will agree. And if I don't, then I offer different advice or different opinion. And so that would be my recommendation is I agree, patients, we don't expect you to know anything about this. And just, start with the general practitioner, get referred to your local endocrinologist. If you're not satisfied or your conditions are going, then always ask for a second opinion and referrals to tertiary academic centers.
Patient groups also have kind of like checklists or guides to your first appointment. We've got a version of that. I know, is it National Adrenal Diseases Foundation, NADF has one. And even some of our, spot supporters and other third parties like cortisolmatters.com is a good website that's like a step-by-step and patient level language, questions to ask your provider to make sure you're getting, but yeah, if you could bring somebody with you, that's always a great idea too. Something like that would be like a really great place for a patient advocacy group to show up, because it would be like a first, like, I had this and here's my experience. I wish I'd asked these questions. You should ask these questions, that kind of thing. So just turn to a patient group for that kind of answer.
Another group that has very good information is the Pituitary Society. If you go there to their website, they have something for patients, and they've actually just come out with a new pamphlet for Cushing's disease. Let me secondary what you said about bringing somebody along with you. I think no matter who you are, even if you're a physician, it's always good if you're ill to bring somebody along with you to help ask the questions you might forget and to understand what's being said to you. Because when you're going to see a doctor and you're ill or you're going to get bad news, it's very helpful to have somebody there who can listen, and because often you can't really hear what the doctor's saying.
Experience of insurance policies you cover.
Yeah. So it really, whenever you ask an insurance question to a doctor, they're going to say it depends on your insurance. Oftentimes in my patient panel, I would say I've only had one patient had to pay out of pocket to see me. And so I think if the referral comes from their endocrinologist asking, like, I need help, this patient's more complex, insurance are often to cover it. But if the patient, if the referral, like they already have an endocrinologist and the patient just goes directly or has a primary care doctor refer, and then the insurance will see, we already gave this referral. So I think the safest way is if that local endocrinologist puts that referral in, because then the insurance will say, okay, they need a higher level of care or something. That's just personal experience. I don't know if that's
No,
true
I
for
think that's
everyone.
absolutely right. And you shouldn't be embarrassed to ask your physician for a second opinion, because if that physician gets upset with you about that, then you need to find another doctor anyway.
So another, this one seems a little bit specific, so I would try to generalize the question. The question is, what if your 24-hour urine cortisol is a little bit high? You had 2 of those dexamethasone suppression tests, and they both show that you make too much cortisol the following morning, and you have a slightly elevated late night sort of salivary cortisol, but the inferior petrosal sinus sampling shows that your hormones are high on both sides. Is this common in Cushing's, or could it be something else? So this is very specific to this patient. So to answer your question, so basically all 3 tests to determine if your cortisol levels are high. So remember when I said, a random cortisol does not diagnose Cushing, right? We have these tests, and so the 3 main is a dexamethasone suppression test, a 24-hour urine cortisol, and then a late night salivary cortisol. That's how we determine whether or not your cortisol levels are too high and you have Cushing disease. If all of those are truly high, which it sounds like for this patient, the next question that we have to ask ourselves is this because of a pituitary issue or not? The only reason why we do inferior petrosal sinus sampling is because we are quite confident that it is a pituitary issue, and we want to know which side the tumor is coming from, so that when the surgeons go to the OR, they aim for the left or the right. If your cortisol level is high because you have an adrenal gland problem, has nothing to do with pituitary, your adrenal gland just for other reasons making too much cortisol, then we wouldn't go for the IPSS. And in this patient, I'm assuming that they had a pituitary source for their high cortisol, and the IPSS was elevated on both sides. And if the imaging does not show a frank tumor, this is unfortunately common. So of all the pituitary tumors, Cushing tumors tend to be one of the smallest. Like you can have a 1 or 2 millimeter tumor that is hard to see, which is why we do this IPSS. And if that doesn't help, I don't know if they would.
Well, the IPSS will distinguish between having a tumor in the abdomen that's ectopically making ACTH, like a lung tumor or a pancreas tumor, and it'll localize it to the pituitary. But it's not uncommon that it'll localize it to the pituitary, but you may not know if it's on the right or the left. Yeah. And it's still in the pituitary, and that means you've got to have a good pituitary surgeon go in and take a look. And sometimes they can look and they can see the tumor, and they'll remove it, obviously. Sometimes when they go in, they don't see a tumor at all, and it hasn't been lateralized, but you're still quite sure that it's in the pituitary. And then the decision has to be made as to what to do. And I think generally what we ask the pituitary surgeon to do then is to take out half of the pituitary and see if they've gotten it on pathology and see if they've cured the patient. And sometimes they have, and sometimes they haven't. And sometimes they have to go back and take out, sometimes we have to do a total pituitary removal, total hypophysectomy. And that doesn't always cure the patient either. So if the tumor is very, very small, or if it may be, in an unusual spot, it can be very difficult to remove.
I think I know who this is. I'm not going to say their name, but there's an additional piece I'm just going to throw in, because if this isn't them, then I know they are watching. So I just want to do this for them. This person is being treated by a fellow, which is giving a lot of doubt about, like, is this the right choice? They've been put on a medication, and this person wants to have surgery, but they were just told, just take this medication and we'll, scan you again later or something. And they're just like, that doesn't feel right to them. And what would you recommend in that sort of a situation where it seems like everything's pointing to a pituitary source of Cushing's, and then they're just being put on the medication?
Well, there are medicines now that can resolve the hypercortisolism. So there's a drug called pasriatide, which is a blocker of somatostatin receptors that sometimes can lower the ACTH. And then there are a number of drugs that can interfere with the synthesis of cortisol. So you could treat somebody with that, and you treat them quite effectively so that they no longer have any of the signs or symptoms of Cushing's, and what they had before can be resolved. And one can treat patients like that indefinitely. And that is an alternative to surgery where you can't find the tumor. One could do the hemihypophysectomy. That's another alternative if the surgeon is comfortable doing that, and if you can't find it on the scan. But I don't think it's unreasonable to do medical treatment. You wouldn't do medical treatment if you had a large pituitary tumor that you could see and easily remove, and there was no contraindication to surgery. Sometimes we have patients who have very severe Cushing's, and we don't really want to operate on them at that point because tissues are very fragile. They may have high blood pressure and diabetes, and we do give them medical treatment and until a lot of things resolve, and then we can go back and operate later. So if you can control the Cushing's with medications, that's not an unreasonable approach in some patients.
So this case is evolving. I'm getting more information. There is a 4 mm tumor in the pituitary gland. The issue is that the IPSS, inferior peripheral sinus sampling, showed high ACTH production on both sides. And so this case is very complex in the sense that a 4 mm tumor on an MRI could be totally an incidental finding. So we see that. It's very common you just have a non-functional. And so that doesn't tell us anything. So even if you have frank Cushing and a 4 mm tumor on MRI, we still recommend an IPSS to determine which side. And so if it's the same side as the tumor, then we go for that. But it's not a guarantee that just because you have a tumor means that that is what is secreting the ACTH. And some people do a cutoff, like if it's big enough, like if it's 6 mm, then we're quite confident, then we can just take that out. But we still often like to do an IPSS to confirm. And it sounds like it did not confirm in this patient. And so like Dr. Hoffman said, it's really a patient decision. If the patient wants to try to go in the OR and then have the surgeon, because sometimes the surgeons are like, oh, this looks very fatty, let's go for that, and do it. But like Dr. Hoffman said, if they don't see anything, the decision has to be made when in the OR, do we take out half? And it's a 50-50 chance, right? You're taking one half and hoping it works. And if it doesn't, you risk the surgery without any of the benefits. And if they do a incomplete pituitary resection, and we're sure it's a pituitary gland, and you get cured, but at what cost? Now you're pan-hypopit for the rest of your life, and you need to be in all the hormone placements for the rest of your life. So it's really a discussion. It's a really risk-benefit and patient preference. Yeah. Mm-hmm. Yes. So you want to go to a place where they do it often. It is a technically challenging place. And so, yeah, and that's where I think second opinions is the best. You want to go to a place where they do it all day, every day. Oh, are we switching? Sorry. Thank you. Okay. Oh yeah, we started late. Okay. Okay. So we're switching. So whoever is in breakout session 2, which is one we're in now, we'll go to breakout session 1, and then, all right. Okay. Thank you, everyone. Yeah. Thank you.